I'm going to introduce you the researcher, Isuroon partner, Nancy Deo, my friend. One of the most compassionate and driven for social justice women I ever met. I know many of them, but she's one of the top. I want to give a little bit about Nancy's background. She can tell you more about it. She's a general management and communication executive with more than 30 years of experience in business and nonprofit sector. For over 13 years, she had worked in women's human rights and African development, and most recently, humanitarian relief. Nancy is currently Senior Advisor, External Communication of Women's Refugee Commission, a research and advocacy organization that improves the lives of women, children, and youth disabled by war, persecution, and natural disaster. Nancy has led maternal infant survival project in Ghana for Millennium Series Initiative and Columbia University project that helps African cities eradicate poverty. It's my honor to introduce my friend Nancy Deo.
Hello and Sodawal for my Somali friends there, welcome. A lot of people have asked me why the interest in Somalia, why the interest in reproductive health. As Fartun mentioned, I've been interested in African development and humanitarian relief and women's human rights for a long time now. And my interest in Somalia began when your war broke out. My interest in the reproductive health of Somali women began when the Horn of Africa drought struck in 2010, and so many women were forced to leave their country. And because we know that 1 out of every 5 women in such a crisis situation is actually pregnant, I wondered, what happens to culture in camps and in foreign lands like the United States and here in Minnesota that become their homes? And in Somalia, where still today 1 in 12 women dies in childbirth, what will it take to save more mothers and save more babies? We realized that the Western medical community, whether they be in Somalia, in refugee camps, or in the US, might have difficulty understanding some of the culture and some of the preferences of Somali women, which led us to this question that you see here up on the screen. How can the Western community more effectively support the cultural preferences of Somali women's reproductive health? Our intent is really to enable the Somali community and healthcare providers to meet halfway, to try to bridge that gap by providing an understanding of each other and strategies for culturally sensitive care for Somali mothers. I want to make a caveat. I'm not an expert in the Somali community, and I'm not a trained medical professional. What I am is passionate about the intersection of culture and reproductive health, and I'm here today to share what so many of you taught me, and I want to speak through your voices. I want to tell the stories that you shared with me. So let me start by saying a few words about the methodology of the research. There are 4 groups that we spoke with across some 50 people that were interviewed: Somali women, Somali men, the imams or religious leaders of Dar al-Hijra Mosque here in Cedar Riverside, and a group of healthcare providers in 3 different clinics. For this research to be credible, it was extremely important that it must be Somali-led. Fartun and Isuroon played that role for me. I'm so grateful because these are very sensitive topics that we're going to discuss today, and for women and men to feel comfortable sharing, it had to be in the presence and led by a Somali organization. And this is in order to be able to be open. So we did 4 focus groups with 25 Somali women in total. Importantly, all had given birth first in either Somalia or in refugee camps, and then in the United States, so we could compare their childbirth experiences across the various places and understand their attitudes about Western medicine. Second, we talked to 12 Somali men in 2 focus groups and a group of imams or religious leaders with the support of a colleague of Fartoon's who I want to mention. Some of you may know him. His name is Dr. Osman Ahmed of the East African Health Project. We felt, Fartoon and I, that the men would feel very comfortable, again, with a Somali man leading, given the sensitive topics we were asking them to speak about. And just a note, all of these interviews, of course, were conducted in Somali so that everybody would feel most comfortable speaking in their native language, and was translated for my benefit so that we could understand, so that I could understand everything they were saying. And finally, we did one-on-one interviews with healthcare providers, with doctors, with nurses, with midwives, from 3 very fine hospitals and clinics to understand their best practices for culturally sensitive care. And I just want to say that these are the people that are doing it right. These are organizations that have been supporting Somali women since they came to the United States in the 1990s. So first, we talked to the women about childbirth. And childbirth is a universal experience. It's something that's shared by women worldwide. It's shared by many of us here in this room today. It's something that bonds us all in very unique and unusual ways. We asked the Somali women, who were strangers to each other, I might note, and especially to me as an American and a Westerner, to share what that childbirth experience was like in Somalia, in the camps, and in the US. I just want to share 3 stories with you, because the journey from Somalia that brought many of these women here to the US, where they are today, brought them to foreign lands with medical systems that could not be more different from their cultural practices, from their religion, and from their beliefs. The first story is about Somalia, and it's about the universal fear that many women feel when they consider a cesarean section. And I'm going to read you because I want to speak from her words. As one woman said, "I was in labor for 3 to 4 days. Finally, we went to the hospital. The doctor said I needed surgery because the long labor made the child breech, and he couldn't be straightened out. My family took me home because they did not want a C-section. It is against our culture. They thought surgery might cause me not to have other babies. After the 4th day of labor, I gave birth to a dead child." The second story is about the rather frightening treatment that was received in an Ethiopian refugee camp. And another woman said the following to me: "I almost died giving birth to my 6th child. I was held for 21 nights at a refugee clinic, and when I had no strength left in me and was almost dead, they transferred me to the hospital. There they asked me to sign away the life of my child or of myself. Of course, I chose the life of my child. I was prepared to have surgery, but just before the doctor started, the lights went out. As a result, they made a hole in my child's head, they crushed his skull, and they found him dead. 13 mothers having babies were transferred that night. Only 1 other infant and myself survived." The third story is about the perceived discrimination against immigrants that many Somali women feel, and was told to me in the following story by one Somali woman. "In the US, as long as you're an immigrant, doctors don't always give you the proper care. I was pregnant, and my child had his umbilical cord wrapped around his neck. When I had the ultrasound, the doctors told me there's something wrong with your baby, but they didn't fix it. When the baby came out, he was strangled by his umbilical cord. I did not take action because I trust that Allah will take care of us, but my baby has a disability from the birth." So what's the message here? First of all, we heard many stories of joy, so let me state there that we heard many very happy stories. but I share these with you because joy and tragedy and everything in between is in the eye of the beholder. And the stories of medicine in the United States can be every bit as scary as stories and tragedies in Somalia and in some of the camps are to us all. So what did we learn? We did an in-depth analysis of the interviews with the Somali community and healthcare providers that revealed 20 distinctions between Western medicine and Somali culture that reinforces the need for culturally sensitive care. There are 8 noted here. I don't intend for you to read this slide because I'm going to take you through them one by one and not force anybody to read because I know that will bore you and put many of you to sleep. So let me start with prenatal care. There are 2 distinctions here. The first is the difference in medical model. The second is the difference in prenatal care. We learned that there was a Somali cultural preference for a curative model. When you're sick or you have a symptom, you go to the doctor. When you're in labor, you find your midwife or you go to a hospital. Versus in the West, there's a preventive model of education, of assessment, of testing, of management of your reproductive health care throughout your pregnancy and through childbirth and beyond. There are 2 quotes I want to share with you. The first is by a Somali woman, and she said, "Here, when you're pregnant, you go to the doctor. At home, you hide your pregnancy." An OBGYN that I spoke with shared a story that was told to her by a Somali patient, which addresses the fact that mothers who have many children may not understand the value of prenatal care. She said, "I've had 8 children in Somalia. All were fine. I know that my baby is healthy because it's moving. So why do I need to come back every 2 weeks and get measured?" So that's prenatal care. Any provider who has ever cared for a Somali woman, and those of you that are providers out there appreciate that Somali women strongly prefer female caregivers. This is really an issue of modesty. I mean, frankly, these women are not interested in showing their private parts to a man who's not their husband. A nurse and an OBGYN both commented to me about their clinic's male Somali residents. In the words of one of them, she said, "We thought when we brought in 2 Somali male residents, it would make the difference. They speak the language, they get Somali women, they know what they've been through, and still they are rejected." There are a number of differences in childbirth practices that I want to speak about, from the length of gestation to the induction of labor to the use of pain meds and more, and I'm going to touch on a few of them that were rather poignant. Somali women spoke of the 42-plus week gestation period. As a result, they're often reluctant to do post-dates testing. One of the midwives I spoke with said to me, "Somali women are my late delivery ladies. They believe that God determines when their baby's ready to be born. I've seen women go to 3 weeks and the baby dies, but they have this amazing willingness to accept whatever God has given them and are at peace with it. We could all learn from them." There is also an aversion that we heard to about the induction of labor. One Somali gentleman shared his regret that the couple induced labor. He said, "The doctors induced labor and my wife still has back pains. We should have waited for natural childbirth." The next is a comment made to me by many Somali women that they don't want to be tied down, which really means, as you can see in this slide, the use of a fetal heart monitor is new to many, and they would just prefer to be walking around while they're in labor, which is very customary back home. There were mixed views in the 4th issue, which was pain management. Some women preferred not to have an epidural. There's a fear that this leads to C-sections, that this leads to residual back problems. Others that may be more religious prefer prayer, but some said pain relief was like, as one woman said, a piece of heaven. So there are clearly mixed views on this. And finally, there's a midwife-supported delivery practice of helping guide the baby out versus the practice here in the West of a woman pushing the baby out. And as the woman said to me, at home, it's normal for the midwife to hold you from the bottom and to push up and guide the baby out. And then you don't get a cut to the bottom, which meant you don't get obstetric fistula. This is a hot button area, and this is the area of cesarean sections. The Somali community very broadly said to me that they didn't understand why doctors do not allow more time in labor for natural births. There is a perceived rush to C-section. One woman was told by her doctor, either sign for this surgery or sign that you don't give your consent and you are responsible for the consequences. It was very interesting to me that the imams told me that the word surgery in the Somali language means slaughter, which was fascinating to me. And in addition to the fears we heard about dying, about losing their children, importantly, there was a fear of the inability to have more children. And why was there this fear? We pushed on why. And there's a story that was told to me by an OBGYN that I think speaks to this fear. She said, I had a patient who had given birth by C-section 7 times. I told her we needed to talk about the risk to her and her unborn children and of having additional surgeries. She had a very, very supportive partner, but nonetheless, she said to me, Somali men, as soon as we stop having babies, they go find another woman. Now, this man said, I stand by my wife, this is absolutely not true. But nonetheless, there were women that told us this fear of not having more children is a reason why some of them have babies every year. Somali men also have strong opinions on why doctors do C-sections. The following quote I found summed up some of the perceptions of the community. He said, in Somalia, most of the births are natural, but here we might see up to 50% of births by surgery. Because of this high number, we think doctors want to make more money from surgeries. They make less if the child was born naturally. They also want mothers to have fewer children. This is why we are afraid of C-sections. Clearly, there is an opportunity on both sides for education and learning about C-sections, about the risks, and about the truths of why they are done. The next topic is another one that's quite a hot button and is very sensitive, and that's the issue of female genital cutting. As all of you who are Somalis know here, this is an important question given that 98% of Somali women were cut as girls, and most are infibulated, which according to the World Health Organization, as most of you know, is the most dramatic form of female genital cutting. But many Somali women told me that doctors generally lacked an understanding. The problem was clearly worse in the early days when the Somali folks first came to the community and doctors had never seen this before. It is still an issue in hospitals and clinics that may not see many Somali patients, but they feel that many doctors don't discuss their preferences for deinfibulation or for repair until they're in labor. They can't concentrate on the issue at hand, and the doctor realizes that in a woman's quote, my opening was too small. There are, however, many in the community, like those that I interviewed, and people like Mary Malatki, who you're going to hear from in a few moments, who have an excellent understanding, and I'm going to let her speak to that, so I won't speak to the culturally sensitive ways of dealing with this, but I will say that the lack of understanding can lead to complications. It has led many doctors in the early days to perform a cesarean section instead of dealing with the cutting that the woman has experienced. It can lead to a midline episiotomy, or as women say, cut to the bottom, which to them means a fistula. Somali women told me they prefer the medial lateral episiotomies or the side-to-side which is cut at 4 o'clock or 8 o'clock for those of you that might not be a medical professional, which they are accustomed to at home. One woman said to me, in the U.S., they don't know what to do, so when the child struggles, and the opening is small, they cut you to the bottom and you can't sit afterwards. I'm not going to say any more about this. I'm going to let Mary address the very sensitive aspects, and I defer greatly to her significant expertise here. There are huge differences in postpartum support between the U.S. and Somalia. In the U.S., it's general that you spend a couple of days in the hospital, and you are then released to take care of your children, your newborn child, and your husband goes back to work. There was much discussion of the tender loving care received by the umul, or new mother, if I'm saying that correctly. I've probably not said that quite right, but of the new mother in Somalia. At home, she is taken care of for 40 plus days by her relatives, her extended family, her neighbors, her friends, who hear that she's in labor and gather around to bring food, to bring gifts, to bring gold, to take care of her newborn, to take care of her existing children, to cook for her. And at the end of 40 days, she is rested, she is beautiful, she's ready to come out into the world. Women dearly miss this support. And here, they're lonely, they miss that, they're isolated, they're depressed. It can lead women to stop wanting to have children, which, as many of you know, goes against the grain of Somali culture. There's a lot we could say about child spacing. I do want to comment on this for a few moments. The term is quite unique to the Somali community, for one. It is, as many of you know, the spacing of births for the health of the mother, her unborn child, and her future children. The imams told me, according to the Quran, the Prophet says that mothers cannot get pregnant if they breastfeed exclusively for 2 years, then there will be 3 years between their children. It was interesting that these particular imams from Dar al-Hijra Mosque said that medical child spacing methods, which meant birth control to them, were not against their religion if it was for child spacing purposes. Yet at the same time, there was a lot of pressure in the community to have large families. And not only are children a gift from God, as the Prophet says, as the Quran says, but there's a lot of family and a lot of peer pressure to have many children. And one man said to me, "My father had 10 kids. I have to have just that many. I want to be just like him." The paradox here is that all men said that child spacing was consistent with their religion, yet if their wife gives birth annually, they are the envy of the community. So there was confusion amongst the men and the women as to whether birth control was allowed by their religion and whether they can get pregnant when breastfeeding, and the answer is yes, you can. As the medical professionals know, if to start to supplement or give your child solid food, you can begin ovulating, so it is possible to be breastfeeding and get pregnant. So there's an education opportunity here to enable mothers and their infants to be as healthy as possible. And finally, in terms of our learnings, many Somalis believe that providers have a one-way dialogue with them, and when the doctor says, "If you don't want this C-section, then find another doctor," they feel completely abandoned. It's interesting to note that two-way communication in this photo in particular is of a physician from Smiley's who is, I happen to know, is beloved by her patients and is an expert in two-way dialogue and culturally sensitive care, which leads us to the next discussion, which is the best practices of healthcare providers. I want to just say, before I comment on them, many of these people have been working with the community since the influx began in the 1990s. These are the people that I sought out specifically for discussion of best practices. What you see cited here are 12 of them. There were many others that are checked here. Mary and Stephanie will talk about others, but they're all key to building trust. As Daniel referred to, it's all about trust. It's all about being heard. It's all about being seen. The first is providing options and consulting with families. It sounds fundamental. It's just good practice, right? One man summed up his desire. He said, "We want doctors to consult with the family, even if surgery is recommended and is the best alternative. We want to know our options, and we simply want to have a discussion about it." Another nurse said to me, "You need to listen and allow Somali women to voice their desires, then you need to educate them on the options and help them make the best decision possible." The second is hiring Somali staff and speaking Somali. Again, this sounds like a no-brainer, right? You should speak the language of the people that you're caring for. Well, in one clinic that I spoke with, they have staff in the reception area that speak Somali. They have Somali residents, both male and female, who are practicing at the clinic. Some went to Somali language classes and learned basic Somali. Another hospital that I spoke to had a midwife that had learned enough Somali to conduct an entire prenatal visit in the language, which is something also to be congratulated. The next two items are very closely related, so I'm going to touch on them briefly. Learn life stories. One OBGYN created a wonderful questionnaire to use in learning life history, and I want to read this to you. She said, "Asking how many kids you have can be a hard question for Somali women to answer. But if I ask first, how many times have you been pregnant? How many children have you successfully given birth to? How many of your children are still living? How many are with you here in Minnesota?" With this type of questioning, we have much more information to build a connection and to deal with and partner with and work with that patient in a much more compassionate way. That same OBGYN has created a lecture that she calls the Introduction to the Somali Patient, where she talks about the war, she talks about what it means to be a refugee, she talks about what the camps are like, she talks about Somali culture, and it's a great tool for understanding how to best work with patients once they come in. So where do we go from here? I'm just going to touch on this briefly because Fartoon's really going to give the big close, so I don't want to give the big close. I just want to say a couple of things. Providers have an opportunity to understand Somali culture and preferences for culturally sensitive care. The Somali community needs information on Western medical practices in order to manage their own care in a new environment. And government agencies have an opportunity to bring the communities together. So let me just touch on recommendations for each. The healthcare providers have an opportunity for cultural sensitivity training to provide this type of care we've been speaking about in the last 25 minutes. These experienced providers, who I was so honored to speak with, have an opportunity to share their best practices. And there's an education opportunity for the Somali community about why C-sections are sometimes required to save the life of an infant or the mother. And there's an opportunity to train medical professionals about female genital cutting. And what about the Somali community? The community is clearly ready to take the lead in the provision of their own health care. They wouldn't have stepped up to the table to talk to Fartoon and myself if they weren't ready. These families have an opportunity to learn about a new medical model, to learn about the value of prenatal care. The imams need education on the range of child spacing practices that are now available here in the West so that they can influence the community. A Somali-led organization needs to take the lead in providing care for the new mother in the 40 days postpartum. That's such a delicate time when she needs that love and support. And finally, interpreters need medical terminology and reproductive health care training so that they know this terminology and can better communicate. And the convening agencies, whether they be a government agency or a Somali-led NGO, have an opportunity here in the U.S. to act as a convener in cross-cultural education to close that gap. And Somali-led NGOs specializing in the care of women should take a leadership role in development of those plans and interventions. There are many messages here also for refugee camps and for Somalia. Just to touch on them, clinics and staff should also be trained in the camps on culturally sensitive care. And given that a large number of home births still take place, there's an opportunity for midwives in the camps to reach out to these women. And given, thankfully, that there is a new president who's Somali in Somalia that was recently elected, there's an opportunity for the Ministry of Health to secure support from development organizations, whether they be here in the United States or overseas, to reestablish the hundreds of wonderful maternal and child health clinics that were destroyed or closed during the war. So I want to just close by saying the goal of culturally sensitive care is within reach. I think the time is here. If the Somali community, healthcare providers, and governmental agencies can come together with these cultural preferences and desires in mind, we can close the gap and take a step toward reducing the maternal and child mortality that takes so many lives needlessly on both sides of the globe. I want to tell you that there will be copies of the research report as you leave that are available both in depth and in an executive summary, and we urge you to take copies when you leave. Thank you to the Somali community, and thank you to the healthcare providers that I spoke with. It was just an honor to serve you both, and Mahad Sanid. Thank you.